Dr. Asteriadis, the importance of real-world data and the real-world clinical effectiveness of ranibizumab.
Thank you very much. Good afternoon, dear colleagues. I'm going to talk about real-world data regarding the effectiveness of ranibizumab. Before I do so, let me just allow me to remind you how it all started. More than 10 years ago, we are all aware of the major studies, the Marine and Anchor, which showed for the first time a significant improvement of the vision by using monthly injections in the vascularized AMD. And of course, this included all the subtypes of choroidal neovascular membrane. And of course, there were more to follow over the years, which justified treatment with anti-VEGFs in the other conditions as well. But of course, since the beginning, it has been obvious that the monthly injection regime, such a strict protocol, it's almost impossible to, or extremely difficult to apply in the long term, in the real world. So this is because it applies a very high burden on the system, on the patients, the doctors, and it's probably not cost effective. So ideally, the aim of an ideal regimen should be to minimize this burden, either by minimizing, for instance, the injections or the visits. It has to be cost effective, but without compromising the results or the efficacy. In other words, it has to maintain vision and it has to keep an exudative-free macula. We have to keep a balance between under-treatment and over-treatment. And over the years, there have been significant efforts over the last 10 years since the initial approval of the ranibizumab to find a way to individualize, so use, in other words, flexible regimens in order to achieve our efficacy. And allow me to just go through some of the modern regimens that we use in the real world. And of course, this is the PRN and the treat and extend. And just to remind you that with both of them, actually, we need to achieve stability of the disease by doing monthly injections. And once we've done that, with the PRN, you have to follow up the patient on a monthly basis. And this is a major disadvantage of the PRN. And if you see reactivation of the condition, then you have to treat the patient again. Whereas with the treat and extend, it's exactly a different concept. You always treat the patient, but you're trying to extend the time intervals by intervals of 15 days or perhaps more, depending on the actual condition. And once you find the exact site in time, the exact point in time where you have reactivation, then you move backward. So it's a more proactive kind of treatment regimen. And there is significant literature to support this. These are the treat and extend studies. And these are some cumulative data of the treat and extend showing a significant amount of improvement by 9 letters in 2 years, with a significant reduction of the number of visits as well as the injections, and that's the important thing. With the PRN, it also showed, again, cumulative data, improvement of vision by 8 letters in 2 years, significant amount of reduction of the injections, but not the number of visits, and that's the important thing. It still poses some burden on the system, but both of the types of regimens decrease the number of injections over time. And that's why worldwide you can see that we have shifted in the real world towards one of the two. On the left is the states and worldwide, and on the right is the Asian populations. So over the years, by extending the initial randomized controlled trials, we now have enough data to support the efficacy of those treatments. And with the exception of the AMD, the pedant up at the top, which showed 12 letters improvement in 7 years, but they followed a strict regimen. The rest of it, after the initial couple of years of a strict regimen, they moved on to PRN, in fact, very flexible PRN. But you can see they managed to maintain the vision over time. But what happened in real life? In real life, things are slightly different. There are different factors which are interrelating, and factors which have to do with the disease itself, or the diagnosis, the patient and the doctor, the health systems and financial factors and so on. So in other words, the randomized control trials are conducted in a controlled environment, and they're not always representative of the real world, and we need real world evidence. And these usually come from other types of studies, observational studies, which trying to sort of bring us into the reality of the real world. Let me just allow me to go through some of these results because there are studies coming up and there will be more in the future. So the Luminous project it has two parts. The first part is a retrospective part and is run in Europe mainly Germany and some other countries. And they're pulling patients, almost 5,000 of those, and they have already published some results I'll show you in a minute. Whereas the prospective one will include different countries all around the world, and they're recruiting 30,000 patients in this registry. And with the first publication, the retrospective study, they've already showed, they have demonstrated that the ranibizumab is favorable, has got a favorable safety profile in the real world. And also there has been another announcement in Euretina 2016 showing that there is a significant gain of letters over a year, but the ones who did better are the ones who had more injections, which is in keeping with the randomized controlled trials and the extent of those. What is the Fight Retinal Blindness registry? This is another big registry which have collected data from patients from countries like Australia, New Zealand, Switzerland, and Europe, and also Singapore. And we're talking about almost 8,000 patients, and the data run almost 10 years in the past. And this data include things like the type of the condition or the type of treatment given and so on. And they have already started publishing results, and I'll show you some of those, which I think interesting. I find them very interesting. The plan is to give results and publish publications which have to do with head-to-head studies, real-world versus randomized control, long-term follow-ups, and number of injections, and so on. So Gillis and the colleagues, back in 2014, initially published one of the first actually publications. What they did is they had a cohort of patients which resembled the characteristics of the Marina study, being pulled out of this big registry, the FRB, and they compared that with the Marina studies. In other words, real world versus randomized controlled trials. And they showed that in the real world, there is a significant gain of letter, not as good as with the Marina, but good enough, but with the less number of injections. It's down to 7 than 12, which is the original Marina study. And the next year, they published some other results, again pulled out of this registry, trying to figure out what's happening in the long term. Most of these cases had a ranibizumab injection, but not all of them. And they showed that these results can be maintained, 4.3 letters gain in 5 years, with a mean number of injections 5 to 6 per year, which is slightly higher than the randomized control trial extensions, but still the results are pretty good. And the ones who did even better are the ones who started off with lower vision, 12 letters in 5 years. And again, the same team out of the FRB, they're trying to compare the two drugs together, Lucentis versus, ranibizumab versus aflibercept. I need to stress that all of these patients, stress again and say again that all of these patients have had, in all these studies, mostly individualized regimens, so PRN or treat and extend, as opposed to the strict monthly. And they showed no significant difference between the two in terms of VA gain, and also the number of injectors appears to be pretty much the same. And then Barthelms in the same year, 2016, announced their results, and they're trying to see whether switching from one to the other, from one agent to the other, may make any difference. And in fact, most of them was a switch from Lucentis to Eylea. And they showed, again, no difference between the two in terms of anatomical results. Irene has already mentioned that. But there may have been in terms of functional results. But in terms of anatomical results, it may have been some difference. And it may have been a slight reduction of the number of injections as well.
So we passed the time. Right?
My last slide, actually. So, finally, the number of visits and injections, according to Ophthaviro, appear to be the same between the two drugs. So, in the real world, the efficacy and safety of ranibizumab appears to be proven, and the long-term efficacy as well. And it appears that the individualized regimens appear to work quite nicely, and they do the trick. And what is needed is that, the factors leading to the optimal result is to have a correct early diagnosis and start of the treatment, to set up a proper individual regimen in order to minimize the under-treatment, over-treatment, and achieve a patient compliance. Thank you very much.
Thank you very much, Dr. Asteriadis. It's okay, it's not me.